Obesity is no longer viewed as a passive condition of excess weight. It is now recognized as a complex, active contributor to disease, especially cancer. While the visual signs of obesity are obvious, the hidden biological cascade it triggers is far more insidious. Beneath the surface, weight gain initiates a series of interconnected cellular, hormonal, and systemic events that prime the body for tumor development, growth, and spread. This is the obesity cancer pipeline, a silent, accelerating process that begins with fat accumulation and often ends in malignancy. At the cellular level, the story begins with chronic, low-grade inflammation. As fat cells, adipocytes, expand, especially in visceral fat depots, they outgrow their blood supply, leading to hypoxia, low oxygen. In response, these cells release inflammatory cytokines such as interleukin-6, IL-6, tumor necrosis factor alpha, TNF-A, and C-reactive protein, CRP. These molecules not only disrupt normal tissue function but also contribute to a pro-tumorigenic environment by encouraging DNA damage, cellular proliferation, and inhibition of apoptosis, the natural self-destruction of abnormal cells. Obesity also alters the balance of key hormones and growth factors that regulate cell division. One of the most powerful hormonal shifts occurs in insulin and insulin-like growth factor 1, IGF-1. In obese individuals, insulin resistance leads to chronically elevated insulin levels, which in turn stimulate the liver to produce more IGF-1. These factors bind to receptors on the surface of cells, activating signaling pathways such as PI3K/ACT and MAPK that promote cell growth and survival, mechanisms that cancer cells hijack to multiply uncontrollably. In women, adipose tissue is also the primary site for estrogen production after menopause. As fat accumulates, more estrogen is synthesized from androgens via the enzyme aromatase. Excess estrogen is a known risk factor for hormone-sensitive cancers, such as breast and endometrial cancer. It promotes cell proliferation in estrogen receptor-positive tissues, increasing the likelihood of mutations during DNA replication. Over time, these changes can lead to the development of malignant tumors. The systemic effects of obesity further exacerbate the problem. The immune system, already weakened by chronic inflammation, becomes less effective at surveilling and eliminating abnormal cells. Natural killer, NK, cells and T cells, which normally patrol the body for early signs of cancer, become dysregulated. Some studies show that obesity induces a state of immune exhaustion, where key immune responses are blunted. This immunosuppressive environment allows emerging tumors to evade detection and grow unchecked. Fat tissue also directly communicates with cancer cells via secreted signaling molecules called adipokines. Leptin, an adipokine elevated in obesity, promotes angiogenesis, the growth of new blood vessels, cell proliferation, and resistance to apoptosis. Adiponectin, in contrast, is a protective adipokine that inhibits cancer-promoting pathways, but its levels decrease in obesity. This imbalance contributes to an environment where cancer can flourish. As tumors develop, obesity continues to influence their behavior. Studies have found that obesity can change the metabolism of cancer cells, making them more glycolytic, dependent on glucose, and more resistant to chemotherapy. Obese patients often have higher circulating levels of fatty acids and glucose, which tumors exploit for fuel. Moreover, the altered vasculature in obese tissue may limit drug delivery and oxygenation to tumors, impairing the effectiveness of treatment and fostering therapy resistance. Even beyond tumor biology, obesity affects the entire trajectory of cancer care. It complicates screening accuracy, reduces surgical safety, alters drug metabolism, and can increase the risk of recurrence. Obesity also contributes to comorbid conditions like diabetes and cardiovascular disease that limit treatment options and reduce overall survival. Despite the profound biological mechanisms linking obesity to cancer, public awareness remains dangerously low. Most people associate cancer risk with genetics or smoking, not with excess body fat. This knowledge gap delays both preventive action and diagnosis. It also hinders effective policy. While governments have launched aggressive campaigns against tobacco, similar urgency is rarely directed at obesity, despite its growing role in cancer epidemiology. The obesity cancer pipeline is not an isolated problem. It is a growing global reality. As obesity rates climb worldwide, so too will cancer incidence and mortality, especially in middle-aged and older adults. Without urgent, coordinated intervention across medicine, public health, food policy, and education. This biological chain reaction will continue to drive preventable suffering and death. Understanding how obesity fuels cancer at every level, from cells to systems, is not just an academic exercise. It is a call to action. Until obesity is treated with the seriousness it deserves as a carcinogenic condition in its own right, efforts to curb cancer will remain incomplete, and millions will continue to enter a disease pipeline that could have been stopped at its source.